now? Get more responses, maybe this time, 73? Okay. It is my privilege to introduce to you the speaker for the session on nephrology, and it is going to be Dr. Sira Sooparb. And he said his patients call him Dr. Sooparb because he's so good. He's a nephrologist. He actually got his medical degree from Mahidol and then went to the U.S. and did a residency in Brooklyn, which is near New York City. Did his residency there and then went to Emory in Atlanta, Georgia, and did a fellowship in nephrology. He has since come back to Thailand. He is now practicing in Bumrungrad, which is, even in the United States, is a famous hospital for the quality of care that they give. The physicians at that hospital are asked to be American board certified, and Dr. Sooparb is. So he has taken all of the exams that you are looking to take. So he's an expert. So he's done well on all of those exams, passed them very well. So without further ado, Dr. Sira.
Thank you for inviting me here. It's very strange to talk to Thai people in English. My first time. Usually it's my friend lecture. We have 5 group practice in Bumrungrad, and she graduated from Labok, and she's a Chiang Mai alumni, but she have some business to do today. So just that. I want you to have 3 things from me, to get from me 3 things. First, you have to learn how to write the medical history. Second, you try to listen how to present to the attending. This is the way we present the case to attending. The third, you have to learn how we think to approach the patients. So we have 3 things to get from me today, not only the knowledge, okay? So let's start. It's always a long history case. This is typical board exams. So it's always long history. So this is 76 years old, male, present to the emergency room. He had influenza. Now present with difficult muscle pain and weakness. His past medical history is remarkable for osteoarthritis, for which he takes ibuprofen, and hypercholesterol, for which he takes lovastatin. Physical examination reveals blood pressure of 130/90. No orthostatic change. The only other finding is difficult muscle tenderness. Laboratory data include the BUN is 30, creatinine of 6, K of 6, uric of 18, calcium is 6.5 is low, phosphate is 7.5 is high, and you have a large blood in the urine with 2+ protein and no red cell. So I want you to answer the question now. Nobody answer a question. 1 people. 2. Usually you have 1 minute and 30 seconds to answer the question. I think it's better than last lecture. Even I don't need to teach you. Okay. The clue is that few things. When you read through the question, you have to the question. You have to get to the question what they're asking. And some clue is that if you have no orthostatic hypotension, means there's no volume depletion in this case. Okay. When you have a rhabdomyolysis, okay, you have hyperkalemia, hyperphosphatemia, hypocalcemia, and blood in the dipstick caused by myoglobin. So anything inside the cell is breaking up, and it's in the bloodstream right now. So that's doing very good job on the first case. For the non-steroidal drugs, it decrease the blood flow, and it less common, can cause interstitial nephritis, but you have to get the clue from the your question is that you're supposed to have an eosinophil in the urine. Okay. Question number 2 is a 20 years old male present with obtundation. I'm going to present about 10 or 15 cases of people with obtundation did not give you the history. Past medical history is unobtainable. Blood pressure is 120/70 without orthostatic change. And he is well perfused peripherally. The neurological exam is non-focal. His laboratory values are as follows. Sodium is 138, K 4.2, bicarb is 5, and then chloride is 104, creatinine of 1, BN 14, calcium is 10, and room air blood gas is pH is 7.02, PCO2 is 15, and PO2 is 96. Blood glucose is 90. And urine exam is normal. So just pause a little bit. Try to calculate anything that you want to check in this case. All right. I give you a time to look in the lab value. So which of the following is the most likely acid-base disorder? Can I go back? Okay. Can you put the question on the left slide? Always do that. Okay. You can answer the question now. Chiang Mai is the most famous about nephrology training, so I guess you guys get everything correct. Oh, see? Always get everything correct. So, question number 2, you have acidosis, correct? It's a metabolic acidosis because you have low bicarb and low PCO2, and the anion gap is 29. So you calculate the respiratory compensation, you're supposed to use the winter formula. It's come out like 15.5 is very close to 15 that they give into the question. So this is anion gap metabolic acidosis with respiratory compensation. It's very easy. So I think this is the way we approach the acid-base disorder for nephrology. You check the pH first. First you check the pH. Is it acid? I'm sorry. Acid or alkalemia? Okay? If it's normal, then you maybe think it's a normal. But sometimes normal can be mixed acid disorder. Be careful about that. Look at the bicarb and the PCO2 and calculate the anion gap. Calculate the predict respiratory compensation and metabolic compensation, and then you see the change in the anion gap and the bicarbonate. All right, it's very easy clue. So, how can you predict the respiratory compensation for the steady state metabolic acidosis? I usually personally use this one. The PCO2 is equal to last 2 digits of the pH. I don't want to remember that much, but if this is a standard formula, okay? You cannot remember anything, just remember this formula. And another easy one is that you add 15 to the bicarb, you got the PCO2 and the pH. This is 2, it's a trick. One we have to use in 10 to 40 milliliter equivalent. Okay, for the respiratory, for the predict metabolic compensation for the steady state respiratory disorder, I think that is difficult, but you have to remember that PCO2 decreased by 10, then the bicarb changed by -2 and -5. If the PCO increased by 10, then the bicarb changed by 1 and of 4. You have to remember that you cannot do anything more than that. Okay, now it's a clue in the question. When you have metabolic acidosis, okay, this is the cause of it. This is diabetes, keto, lactic acidosis, but this is a trick question. You have to remember this situation: short bowel, confused, and normal lactate in the blood. You have to think about the lactate. You cannot detect that in the blood. You give the glucose to the patient and then patient wake up. Alcoholic ketoacidosis, toxic alcohol. In Thailand, they don't have a lot of antifreeze because we not freeze, but in America we have problem with the car. So they have to put antifreeze inside the car to prevent the machine from freezing. Nobody explained to me in the first go to America. This is the thing that you have to, oops, sorry. This is the thing that you have to really remember, ethylene glycol. They love to be on the board. People come with metabolic acidosis, high osmolar gap, and the calcium oxalate in the urine. Always ask in the round, okay? And the methyl alcohol, you have high osmolar gap without urine calcium oxalate. Salicylate, renal failure, and toluene, love on the board also. Toluene is glue sniffing. People have history of painter. Okay, you have a painter, you think about toluene or ethylene glycol. This is the calcium oxalate crystal. You have to remember the picture. It's like an envelope in the urine. Okay, how to calculate the osmolar gap? It's very easy. You order the lab to give you the measure osmolarity, and then you calculate the osmolarity, and you minus the measure to the calculate osmolarity gap. Calculate, this is the formula: 2 sodium, BUN, and glucose. Roughly you use 2 times sodium is equal to calculate osmolarity gap, okay? Normal is no different, about less than 10. So anything that you cannot measure in the lab, it will come up in a measure osmolarity in the blood. So it's ethanol, methanol, antifreeze, isopropyl alcohol. This is different. Isopropyl alcohol. If you have this kind of toxic metabolite, it cannot cause the acid in the blood, but it can cause the osmotic gap, more than 20. So another big case number 3, 83 years old, woman, present for follow-up hypertension, type 2 diabetes, depression. She complained of fatigue, mild dependent edema. Her medication include the water pill, atenolol, glyburide, paroxetine, antidepressant. Physical examination show blood pressure is a little bit high, weight 42 kilo, clear lung field, normal liver spleen, 1+ peripheral edema. She appear mildly pale. The CBC show MCV of 87, anemic, normal white cell and platelet. Chem profile shows sodium 136, K 4.9, bicarb 18, chloride, this is 108, creatinine of 1.5, glucose of 178, and liver enzymes normal. So when you have this big question, usually I don't read the question, I read really what they're asking. You see the question first, and you go back and read the long case. So you look at they ask about the anemia. So we look at the anemia, what caused the anemia, all right? I think we're going to get 100% correct. Nobody say yes. Okay, can I have the answer now? My body is smaller than the previous speaker. So they always answer the correct question. Usually they want to know, this question is easy. Is anemia of chronic disease, okay? They want to ask you the knowledge about to know that you know that the patient have a kidney failure. So very easy. So you calculate the Crocov-Gauss formula. I think all of you know about this formula. You don't need to do anything much. And you calculate this girl have like 19 cc per minute. So it's like stage 4 kidney failure. This girl have kidney failure induced anemia. So when you have the normocytic anemia, make sure that you check for the kidney failure and anemia of chronic disease, endocrine deficiency. If you're macrocytic, you check for the folic, B12, microcytic anemia, iron deaf. Diabetes is not inflammatory disease. Does not cause any anemia of chronic disease. Remember that. You don't need to write it down. I give the handout to the secretary. Fourth question. 53 years old male with septic shock developed renal failure with serum creatinine of 6.4. Which of the following is a specific indication to initiate dialysis? I think Chiang might have a lot of case coming for the dialysis. I think you know this one in your heart and mind. Okay, can I have an answer? Let's see. Oh, I think you're going to jump out the window. I'm going to tell Dr. Dusit today. Okay. Okay, few things you have to know about the dialysis indication. Okay. Indication for dialysis is uremic pericarditis, because if you have the friction rub, people will go to have the effusion around the heart very easily and very fast. You have to do the dialysis right away. It doesn't matter how much the BUN, how much the creatinine, you have to do it right away. Encephalopathy, the same thing, you remain into the brain. Volume overload, okay? Without you cannot correct with some medication. And intractable hyperkalemia means that you use all the medication, it doesn't work. To go back to the BUN rise to 75 is not correct. The last paper that we reviewed, the level may be used at 100 milligrams per deciliter. Okay, urine output fall to less than 10 cc. You have to correct the problem. Like you have low volume, you give the volume. You have shock, you have to fix the shock. You have sepsis, you fix the sepsis. Not indication for the dialysis. Okay, and continuous hypotension. You usually not even talk to the patient for the dialysis yet when you have hypotension, because the machine can make the hypotension get even worse. So you have to fix the problem first before you go for the dialysis. All right. So the main thing is that you have to remember the uremic symptom. Okay. Now we get the. This is my medical school for my residency training. It looked nice outside, but it looked a little bit difficult inside. Case number 5. 68 years old woman. See, a long history case. This is typical clinical case. It's long history. So before you read it, you go to the answer first. Okay? This is the way I'm doing. I look at the answer question and then I go back to the first one. Okay. 68 years old woman with stable coronary artery disease undergo aortogram with lower extremity run-off study for peripheral vascular disease. 90% of the time, people who have the coronary heart disease will have peripheral vascular disease. So be careful about that. If the patient comes with a peripheral vascular disease, you have to check the heart first, not send the patient for the operating without checking the heart. Okay? And the patient taking warfarin. Okay, aspirin, lisinopril, metoprolol, atorvastatin, beta blocker. You just learn about that. She received a course of decloxacillin for cellulitis a week ago. Why they told us? Because they want us to think something. 3 weeks ago, she got an angiography. Now she come back with malaise. Physical examination review petechial rash and livedo radicularis. In the board, sometimes they don't show you a picture. I show you a picture. This is livedo radicularis. Okay, and this is petechia, and this is purpura. So you have some idea. Lab show that the creatinine is jumped from 1.5 to 3.7. If the creatinine above 1.5 in 24 hours, means that the kidney is not working at all. Okay, and the ESI is high, leukocytosis, eosinophilia. Not many diseases have eosinophilia, and C3 is low. Urine sodium is 40, not low. Urinalysis is that 5 to 10 eosinophil, 10 to 20 white cell, 5 to 10 red cell, no CAS, and 1 plus dipstick proteinuria. What is the most likely? They don't tell you a definite diagnosis, the most likely diagnosis in this case. You see a lot here. You do like cardiac cat, maybe like 50 a day here. So what do you think? Low C3, eosinophil, it's only one disease left in your brain. Nothing else. Don't use the rule that the longer is good. Sometimes some people use the longer answer. Okay, can I have the answer now? You got 100% right this time. Nobody sleep, that's good. Oh my God. 30% correct, 13% correct. I'm going to tell Dr. Dusit again. And many of your nephrology attending. Clue. Don't worry. That's why I come to teach you. Okay, urine sodium above 20 rule out any hypovolemia. That's you have to keep in your brain. They show you urine sodium above 20, just rule out the hypovolemia. Radio contrast media induce kidney failure on the 3rd day, not on the 1st day. Peak on the 3rd day. Okay? Interstitial nephritis doesn't cause hypocomplement. Never cause hypocomplement. Never at all. Okay? And if you have the acute glomerulonephritis, you're supposed to have red cell cast in the urine in the board exam. It's not going to be difficult not to give you the red cell cast. So this patient have, they call arterioembolic renal failure. Okay? Warfarin, that's why they give you the history of warfarin. You're taking warfarin, and you have the petechial, livedo radicularis, they have the blocking of the small vessel, right? And sometimes they give you the picture of the eye, called Hellenhorst plaque, okay, or eosinophiluria and hypocomplement. So tomorrow you see the patient with eosinophilia in urine, you ask the attending, I want to send the C3 and C4. And the attending said, what? Because it costs you a lot of money here in Chiang Mai to send the C3 and C4. So be careful with that. This is Hellenhorst plaque. You can see it's a bright spot in the artery in the eye. Nice picture. Sometimes they give you this picture and ask you what the disease the patient have. So I give you the picture also. Okay? Some weird name, but looks nice. Question number 6. Doing good. We have 50% pass rate now. You cannot see? Oh, ทั้งอันใช่ไหมครับ Okay. So we're going to read the question and answer. Question number 6. 47 years old HIV positive man. You are really familiar with HIV positive in Chiang Mai, right? It's brought to you for the emergency room because of weakness. The patient have HIV nephropathy, adrenal insufficiency. He take trimethoprim, sulfamethoxazole for PCP prophylaxis, and he's on the triple therapy. He was recent start on spironolactone for ascites due to alcoholic liver disease. So this guy is a mess. He have HIV, he drink alcohol, he come in the ER at night, usually on Sunday, and come back again on Monday. Okay? His physical examination is normal vital signs. His muscle is very weak. Frequent extrasystole are noted. He has mild ascites and one peripheral edema. Laboratory studies show serum creatinine of 2.5. Potassium is 7.3. In EKG show peak T wave and QRS complex division of 0.14. And usually they don't give you the EKG, or sometimes they give you the EKG but doesn't tell you what they're reading. This is the EKG of him, right? It's called peak T. Sometimes you cannot see on the limb lead, you can see on the chest lead. It's like some people pull the T wave up like that. If you pull more, they go to B tag. You press it down, you give something to the patient. Okay, so what is the most important immediate treatment? Read the question carefully. Every time you have to read the question carefully. I repeat you many times. Even though you know the subject, sometimes you cannot answer the question. So what you have to give to the patient immediately? Sodium polystyrene sulfonate. Okay, excellent. Acute hemodialysis, call the fellow to come and do the dialysis. Give the normal saline, because I cannot think anything, I just blank. Give you IV calcium gluconate. That's a good choice? No? I don't know. Give the furosemide, because I'm a kidney doctor, I give you the Lasix to get rid of the potassium from the body. So which one is the immediate treatment for the patient? For the USMLE test is for the one before you go for the training. So they ask you only the life-threatening disease. For the fellowship board is another story. Okay. So can I have a quick answer now, please? I think you're going to get it 100% correct again. I always have this feeling inside me. Only 3 people answer. 17 now. So half of your patient die. Nobody treat the patient. Now 77. So 100 patient will die because the doctor doesn't answer the question. That's correct. You have to know this. You have to give the calcium gluconate to stabilize the membrane first. If you call the fellow, it takes forever to come and do the dialysis. Okay? You give the sodium polystyrene sulfonate, it takes about 6 hours to make the potassium coming down. You give the Lasix, it may not work, or it can work, it takes 2 hours, 3 hours. Normal saline, forget it, just throw it away. So when you have hyperkalemia and EKG change in the ECG, you have to fix the problem. Admit to the CCU or ICU. Don't keep the patient in the ER. Please don't do that in America. In Thailand, we know that people, oh, hi, topic T, you give the calcium and wait 2 hours, give another K excellent. You don't do that in the American resident. You admit the patient to intensive care unit and treat it. Okay? I drip the quinidine on the normal floor in Thailand, but you have to drip the quinidine in the ICU in the America. So that's different thing. Okay. So you have to treat it. Calcium is always the answer in this type of question. And it asks you in the USMLE, it asks you in the resident board, it asks you in the fellow board. Okay? Every time they ask the same question. So another question is 30 years old male is brought to emergency room from prison where he works in the paint shop. Why they give you the history of paint shop? Every time they give you some history, you have to think about that. Why they give me this history? He barely arousable. Nobody in the exam is going to talk to you. Usually that because they don't give you the history. Okay? But has no focal abnormality. He has normal blood pressure, mean that he's not shocked. Vital signs stable. He has no past medical history. CT scan the brain is normal. Always do the CT scan brain when you have patient come with confused. White cell in the complete breakout is normal. Imply something? No infection maybe? Urine toxicology screening is negative. Now, make me headache. And ethanol and acetaminophen is not detectable, mean that I'm really sure there's none of this problem. Laboratory data is as follows. Sodium is 135, K of 3.2, chloride is 75, bicarb 24, creatinine 1.2, glucose 110. Other blood gases, pH is normal, PCO2 is 40, PO2 is 88. So the chief resident send the patient back home. You're going to get sued with that. So which of the following tests we provide the key? Read the question. Which of the following tests we provide the key to correct diagnosis? Serum ketone, serum lactate, serum creatinine kinase, measure plasma osmolality, magnetic resonance scan of the brain, of the head. Let's go back to the lab data again. This is a real life case. And the resident tried to send the patient home, but the chief resident blocked them to do that. Remember the approach I just tell you about the acid base? Look at the pH first. Look at the PCO2, the bicarb. Calculate the correction. See the gap. And then do see the difference in the gap. So can I have a question, please? The question may be a little bit more difficult when it goes through. Another 100 patients die. Nobody answered the question. Only 76. Oh, let me try that. Oh, Dr. Dusit going to be very pleased that you answered the D. The D is correct. Okay? Okay. This one is a little bit difficult. That's why the resident sent the patient back home. It's a paint shop, right? He works in the paint shop. The thinner that we use in the paint is ethylene glycol. All right? And you calculate the anion gap acidosis is 36. You're supposed to have bicarb very low. But you have bicarb at 24, right? So patient has supposed to be vomiting or something, lost some acid from the body. And that's why you have combination metabolic acidosis and metabolic alkalosis. Okay? And normal blood pressure, normal white cells, rule out any infection. And normal sugar level, probably rule out the diabetes. So the most likely answer is that you have to get the osmolality, so you have the gap, so you think that it's probably the toxic alcohol. Okay? Paint shop bring you something in the brain. Even though you don't understand the acid base, you can answer the question. This is Emory. Emory is a nice university. You can work here in the building, and then this is the hallway. And when you get tired with this nice room, you can go across the street, go to the museum, and see the mummy. It's only one in the world, I think. You can walk, see the mummy. Okay. Question number 8. 73 years old male undergo abdominal aortic aneurysm repair. Aneurysm repair again. They love this kind of question. Post-operatively, his blood pressure is 110/70. Heart rate is 110. A little bit high. Surgical wound is clean. Foley cat is in place. Why did you give you the history of Foley cat is in place? Urine output dropped to 40 cc per minute. Oh, sorry, per hour. And the creatinine rise from 1.5 to 2.2 milligrams per deciliter. Hemoglobin are stable. What it implying? Potassium is 4.6, uric is 8.2. Okay. So he go to operating room and then get the operation already. Now you got consult because the creatinine going up. It's normal. It's always do that, right? You get into around, they call the fellowship to see the patient creatinine going up. Fix the problem. Which initial diagnostic test is most useful for the patient? First, urine sodium, urine creatinine ratio. You want to check for FeNA, probably. Urine analysis, renal ultrasound, urine uric acid to creatinine ratio, CT renal arteriogram. Can I have an answer, please? I think I am to go on sooner, finish faster than I think. 100 people will die again. Nobody answered the question. I'm going to kill you. You live in Bangkok, or you live in Chiang Mai. You're supposed to do the simple test first. Remember, simple come first in the exam. I'm going to kill this guy, 18 people. How the world you send the CT renal arteriogram? The creatinine is going up and you kill the kidney right away if you give the contrast to the patient. Okay? And, oh sorry. Okay, the answer is urine analysis, okay? The clue is, oh, it doesn't work here. The clue is that initial, in the question, initial, you are the medical student, you're supposed to send the urine exam in every case that have a kidney failure. Okay? Then do the simple test first, that's the rule. Because fractional excretion of sodium cannot use when the urine is more than 20, period. If the urine above 20, you don't need to send the FeNA, it doesn't work. Okay? And the urine sodium is less than 10, and fractional excretion of sodium less than 1, mean that you have the pre-renal azotemia, mean heart failure, volume depletion, or something else. If urine sodium is above 20 and the fractional sodium above 2 suggests of ATN. But you do have something else, like you got the Lasix. Some people give the Lasix to the patient. Some surgical student, surgical fellow just give the Lasix. And the urine show, in this case, show the muddy brown class, granular class, okay? It's a degeneration of the cells in the tubule. Let's go to the urine analysis. I just want you to see this cast. Make sure that you look at the urine every time you see the patient who have a kidney failure. Because if you have this cast, it strongly suggests that you probably have, the people have glomerulonephritis from some type, 28 to 86%. And if you have this leukocyte cast, it suggests of GN also, and infection, pyelonephritis. Okay, just remember that. I can't imagine how many people give you the cast picture in the lecture. I don't think they give you the picture of the cast. And this is the epithelial cast. It's very specific for the ATN, acute tubular necrosis. If you have this cast, only one in one slide, you diagnosis of ATN. Okay, it's very cheap. You're supposed to do the urine exam. And this is the crystal. You're supposed to know this is uric acid crystal. Okay, if you have uric to creatinine ratio above 1, and you people coming with kidney failure after the chemotherapy, and they show this picture. So think about uric acid nephropathy. I show you the picture of calcium oxalate already. This is another picture of calcium oxalate when the pH around 5.4 to 6.7. You like a drum. And this is calcium phosphate picture. When you have a question about the stone and they show this picture, you have to think about the calcium problem. Okay? And this is triple phosphate. Just remember the picture. 99% of the crystal in the urine is coming from like transient problem like food, dehydration, urine pH, temperature. But if you have persistent crystal in the urine, you think about hypercalciuria, hyperoxaluria, hyperuricosuria, right? And this is, I want you to remember the picture. This is eosinophil in the urine. If they show this one in the urine, you have to think about two things: interstitial nephritis and arterial thromboembolic disease of the kidney. From your knowledge, you're supposed to use TIMSA. Don't use the right stain. It doesn't work. Right stain detect only half of what a Hansel stain used to detect eosinophil in the urine. Okay, another urine, because I'm a kidney doctor, I show you the urine. This is the fat droplet or lipid droplet, okay? Try to look at plenty in the urine that you have here in Chiang Mai. You just keep looking at it and you can see it. And this guy is like a fat inside the cells. After they eat a lot of fat, it becomes called overfat body because it's stuffed with the fat inside. And this is very typical. If I show you this picture, this is cholesterol crystal. Happen to be in the people who have a lot of protein in the urine. Okay. So urine lipid, you have two clinical disease that you can have is a lot of protein in the urine and lipid storage disease called Fabry disease. I don't think they're going to give you this disease in the USMLE exam. Question number 9. 25 years old man is referred to you because of hematuria. 25 years old man. He noticed brief reddening of the urine with recent respiratory infection. The gross hematuria resolved, but his physician found microscopic hematuria on 2 subsequent first voided morning urine specimens. The patient is otherwise healthy. He does not smoke. His blood pressure is 114/72 and the physical exam is normal. He's healthy. Urine analysis show 2+ protein, 10 to 15 red cell with some dysmorphic erythrocyte. No white cell or CAS are seen. Sometimes they show you the picture of dysmorphic erythrocyte. This is dysmorphic. So it's different in shape, in size, and membrane. Okay? And this is the normal one. This is normal isomorphic erythrocyte. This one GN, this one is something that can cause the bleeding in the urine. So, which is the most likely cause of his hematuria? Kidney stone, red cell carcinoma, acute post-strep GN, chronic prostatitis, Buerger disease. What the heck is Buerger disease? Can I have an answer now? You have to get it right. One people answer the question. 2, 7. 100 patients die again. Don't use the longest answer. I told you, don't use the longest. Do you know the Buerger disease? It's an IgA. They don't give you the easy one. You not give you IgA nephropathy, and you're supposed to know about the thing. All right. You have. They give you some twist question all the time in the board. Okay. So dysmorphic erythrocyte protein in the urine exacerbated with infection in young man. If you go back, acute post-strep GN takes 2 weeks at least. Okay. Second, post-strep GN supposed to have edema in the leg and high blood pressure. They don't have that. That's why it give you the question. That's why the question gives you the blood pressure of 114. So usually they have 2 choice left all the time in the board. All right. You choose between these 2. Which one? If you don't sure about the last one, what the heck is a burger? But you know that it's not the C number. You just have to choose the burger disease. Okay. That's the way we do exam. You don't need to know everything. You just know enough to answer the question. Cool. So this is very common in Thailand. It's very endemic here in Thailand. Patients come that complain a lot when they have the infection. Usually it's the upper respiratory tract infection. They have blood in the urine. Okay, skin infection also. So people can go to have end-stage kidney failure if they have a lot of protein leak in the urine. If the patient have no protein leaking or less than 1 gram or less than 500 milligrams per day, Dr. Dusit will tell you that you don't need to treat the patient. Above 500 milligrams to 1 gram, you're supposed to give the ACE inhibitor. Above 1 gram, you have to use some kind of immunosuppressive medication or ACE inhibitor. You don't need to know that because you have to be the resident to know that. Okay, now, 17 years old male is brought to you to the emergency room again, confused, nobody talked to you. My 10 case, nobody talked to me. And in coordination, he's uncooperative and refused to provide any further history. That's why you have to look at the lab. That's why I choose to be the kidney doctor. I don't want to talk to the patient, I just look at the lab. Physical examination reveals this rate of 30. The vital signs are otherwise normal. Normal means normal. You don't need to think that it's going to be low blood pressure. Normal means normal in the board exam. The vital sign is normal, as in the general physical examination. Laboratory values are as follows. A lot of electrolyte again. What you expect? I'm a kidney doctor. Sodium 135, K 2.7, bicarb 15. You go to my algorithm. Chloride 110. Arterial blood gas pH 7.28. PCO2 30. These last 2 digits always correct. PO2 92. Urine pH 7.5. Glucose negative. Why they give you a glucose in the urine? Why don't give you anything else? They give you the glucose. Calcium 9.7. And why they give you the calcium again? You have to think. And the phosphate at 4. Think about that. Don't change the picture. Don't change the electrolyte on the left hand. Now, question is that, which of the following is the most likely cause of the acid-base disorder? Is a GI loss owing to the diarrhea? It doesn't tell you have a diarrhea a lot. You have proximal, renal, tubular acidosis. And you talk to yourself, I hate this word. I hate the RTA. How am I going to know about this RTA? I'm going to teach you today how to know about the RTA in 5 minutes. Disorder of the renin-angiotensin system. What they talking about? Is it RTA again? Distal renal tubular acidosis. Another RTA. Has to be supposed to be RTA question. E, respiratory acidosis. Now you rule out the E. Don't answer me the E, okay? Just choose the first 4 one. I give you one answer. So give me the answer. Chiang Mai Hospital supposed to get the RTA correct. One of the most famous RTA guys in Chiang Mai University. Oh. Somebody get it correct, and it's very good. 37 of you got it correct. Distal renal tubular acidosis. Wow, you're much better than some of my colleagues. Okay, so how we approach that? So when you look back, it's a normal gap acidosis, correct? You look back. You look back is 25 minus 35 is 10. So 10 is normal gap acidosis. So normal gap acidosis, you have only 3 options in your brain. Very easy, 3 options. Nothing else. 3. Want to be diarrhea? Okay. Or it can be renal tubular acidosis. Or it can be people on a TPN. This guy just come to the emergency room and doesn't have time to get a TPN. Total parenteral nutrition. Okay. So when you have the normal gap acidosis, you look at the urine first. See, always look at the urine. If you have glucose and the blood show hypophosphatemia, hypouricemia, normal blood sugar, now you have Fanconi syndrome. So you're supposed to get it RTA type 2. And somebody going to ask me, why they choose the RTA type 2 to be the proximal renal tubular acidosis? Because they found later than the distal. When they found the distal, they called the first one, RTA type 1. Okay, if the urine show pH of above 5.5 and hypokalemia and patient acidosis. So only one disease that you're going to get is RTA type 1, distal RTA. So look at the urine, look at the blood, you get these 2 diseases off your mind already. Very easy. And if urine pH is less than 5.5, now you have big problem because the RTA type 2 and type 4 can, type 2 can have the same thing like diarrhea, hypokalemia. So you have to check the urine ion gap to look for the ammonia secretion in the urine. What is the urine ion gap? Urine ion gap is the one of the most fun thing to do in the board. Because if they give you the urine sodium, urine chloride, and urine potassium, you're supposed to do urine ion gap. They show you how much ammonia is secreted in the urine. Okay, ammonia secreted in the urine every time you have the acidosis. It's secreted with the chloride. So if you have metabolic acidosis, you have to secrete a lot of ammonia, right? But you cannot measure ammonia, you can measure the chloride. So the formula will come back negative. But if you have problem with secrete ammonia like renal tubular acidosis, the urine ion gap can be positive. Very easy. Okay? So if the positive urine ion gap impaired, so it's RTA. Yes, I repeat myself. Sorry. So now we have to go through the RTA stuff. I don't give you the lecture like your professor going to do. I give you the point to remember. Okay? The distal RTA, they found first because they have the hypercalciuria and they have a renal stone. That's why you have a calcium in the urine. They find Sjogren disease, SLE, and rheumatoid arthritis. So in the body, usually I always ask you about the people with dry eye, dry mouth, have kidney stone. If they come like that, you think about the RTA type 1. Hyperparathyroidism, vitamin D intoxication, and toluene. Be careful about toluene, lithium, and phosphorysin B. Hypergammaglobulinemia and urine pH supposed to be above 5.5. Only one renal RTA that have urine pH above 5.5. Nothing else can do. And sometimes they give you this picture. This is the calcium in the kidney from the distal RTA. So this diffused in the kidney on the cortex. So we go to RTA type 4, the easiest one. Suppose they have high potassium, no stone. In diabetes, aldosterone deficiency Addison disease, anything that block have no renin and aldosterone, interstitial nephritis, because this interstitial nephritis make the cell that produce aldosterone dead. HIV, the same thing. Sickle cell disease, the same thing. Lupus, the same thing. Obstructive uropathy, the same thing. They make to go to the same mechanism. And renal transplant rejection, the same thing. They block the renal aldosterone pathway, and urine pH can be less than 5.5. Coming from, that's why the question about the renin aldosterone system, you have to remember this in your practice from now on until you die. This is the medication that can make the RTA. The new one is aliskiren, renin blocking agent, we don't put it here, and spironolactone, ACE inhibitor, trimethoprim, pentamidine. Okay, heparin. Heparin can cause hyperkalemia. Always on the board. Always. Remember heparin. You're going to be the very nice resident when you go to train, because you know about heparin can make the high potassium. NSAID and cyclosporin. The last one is proximal RTA type 2. Proximal RTA type 2 is a bicarbonate wasting from proximal tubule. It's not equal to Fanconi. Fanconi have proximal RTA is like a subset of the Fanconi syndrome. It happens in multiple myeloma. So people who have, look like have high protein to albumin and have glucose in the urine, you have to think about multiple myeloma. Amyloidosis, lead, copper, mercury, cadmium, any heavy metal poisoning, HIV drugs, acetazolamide, 6-MP is an anti-cancer medication. To complete it, somebody going to ask me about the RTA type 3. RTA type 3 have no longer exist now, considered subset of type 1. It's combination between distal and proximal. In the younger adult, and then when you then grow up, become distal only. You don't need to remember that, it's very rare. Question number 11. 1 hour for 11 questions. You're going to fail the board. 56-year-old man presented with hypertension and peripheral edema. Is otherwise healthy. Take no medication. Family history reveals that his father and a brother have a kidney disease. They give you a family history, have something in their brain why they give you family history. His father was on the hemodialysis before his death at age of 68 of a stroke. What? Kidney disease caused you kidney failure and stroke. Okay, and physical examination have the hypertension 174/96, AV nicking. Why they give you the AV nicking? Just want to confirm that it's very hypertension for a long time. Soft S4, bilateral flank masses measure 16 centimeter in length and are palpable. Urine is show 15 to 20 red cell, trace protein, but otherwise normal. His serum creatinine is 2.4. Usually they don't give you the which is the most likely long-term complication of his condition. Sorry. A, end-stage renal disease require dialysis or transplant. B, malignancy. C, rupture cerebral aneurysm. D, bilateral obstruction owing to cystic disease. E, dementia. I give you the clue. Just cut out the E, dementia off. Otherwise, I don't want you to answer dementia. So, I give you like a minute to read about that. Hypertension, mass in the belly. Very common in Thailand. Not that common, but common. They always give you a real life case. Okay, can I have an answer, please? I think my lecture is easier than basic science lecture. Oh, it's always like that. Always come two questions. Divide by two questions. The answer is A. You have to read it again, the question. Most likely long term. Complication. Most likely long term complication. So everybody going to have the bleeding in the brain? Come on, how many people you see bleeding in the brain from the kidney disease? Not much. So, adult polycystic kidney disease, that's what he have. Okay? Few things you have to remember about this disease is that if you have ultrasounds above 40 years old and have no cyst or only one cyst in both kidney, you rule out this disease from your brain. So like you have a family member who have a polycystic kidney disease, and this guy come and ask you, like 41 years old like me, ask, how can I rule out this disease? Just send them to ultrasound. If they have no cyst, they have no kidney disease from polycystic kidney disease. Very easy. Just send the ultrasound. If the patient, another question come like 30 years old, want to donate the kidney to their parent who have adult polycystic kidney disease, even though the ultrasound is negative, you have to go to do the gene linkage analysis. You have to do the gene confirm. So that's why you have to remember this thing. 40 is a cutoff point. Above 40, ultrasound is no cyst or one cyst in each kidney, you rule out the adult polycystic kidney disease. 75% of patients by age of 70 will end up need a dialysis. That's a lot. Okay? Okay. So, patient with a family history of intracranial aneurysm appear to be a greater risk, but only, you can see that it's only 22% risk, not 75% risk. So the risk is there, but it's not higher than the dialysis. This is a picture of the adult polycystic kidney disease. If you see this patient, you try to palpate the belly, you can confuse the mass on the belly. Question number 12. We have 100 questions today, so we come to finish at midnight. So, 73 years old female, arthritis, present with confusion. Confused again, I know. Neurological exam is non-focal, and the CT head is normal. The ER doctor in America always do the CT scan. Patient come with confusion, they do the CT scan to rule out anything. So, laboratory data include sodium 140, K3, chloride is 07, bicarb is 12. Old age female have history of pain in the knee. Arterial blood gas, pH is 7.4. Again, PCO2 is 24, PCO2 is 62. What is the acid-base disturbance? A, respiratory alkalosis with appropriate metabolic compensation. High ion gap metabolic acidosis with appropriate respiratory compensation. Combination metabolic and respiratory alkalosis. Oh, I write the wrong one. No acid-base disorder, hypercholemic metabolic acidosis with appropriate respiratory compensation. I think I give you this one out because I write the wrong patient. Have to be combined metabolic acidosis with respiratory alkalosis. I'm sorry. This is typical case of salicylate poisoning. Normal pH, right? The clue. Low PCO2 have respiratory alkalosis. Oops. Okay. Okay, and metabolic acidosis. And CAP is 21. You cannot get any compensation back to normal. You have normal pH and have the bicarb of 12, you have to have combination mixed acid disturbance all the time. Okay. And this is classic salicylate intoxication. Always come with old age, have some kind of pain in the history, and come with acidosis. Okay. Old patient, history of arthritis, anion gap acidosis with suppression It's anion gap acidosis because it suppresses the oxidative phosphorylation of salicylate and lactic acid. And aspirin is the stimulation of the brain to breathe. So that's why you have respiratory alkalosis. Question number 13. 17 years old, young man coming again. Young woman, I'm sorry. Young woman present with peripheral and periorbital edema. She has been previously healthy and take no medication. I think you guys see a lot of patients like this in the clinic, right? Her blood pressure is 146/92. She is afebrile. She has mild basilar dullness on lung exam. Her cardiac exam is normal. She has periorbital edema and soft Dolly 3+ edema in her leg. Okay, one clue. Every time you examine the patient, don't press the edema here. Press on the pre-tibial area. Okay, for your CS exam. Okay, her serum creatinine is 0.6 and the serum albumin is 2.1. Urine analysis is 3+ protein, no red cell, no white cell, nothing. Some oval fat body, I showed you the picture already. What is the most important diagnosis test? Read the question again. What is the most important diagnostic test? Okay, can I have your answer, please? It's going to be very fun. Dr. Dusit is going to love you. Going to answer the correct answer right away. Because he's not here in Chiang Mai right now. He's in America. I know that they're going to answer like this. This is, okay, now you in the examination for American exam. You don't use the Thai approach for American exam. Okay, I know that Thai people have 17 years old edema, protein leak. You don't do the kidney biopsy. You treat first, right? Wrong. Read the sentence. Her blood pressure is 146/92. She is not pure nephrotic syndrome. She have hypertension. You have to look for anything else more than minimal change disease. Okay, so if the patient comes with massive proteinuria, in America it doesn't matter. It's normal blood pressure, high blood pressure. You have to do the biopsy. For Thailand, if the patient comes with everything normal except the protein leak in the urine, you can try treat the patient first because we want to save the money. But for the American board exam, do the biopsy first. Okay? Don't treat it first. Do the biopsy. So nephrotic syndrome is a heavy proteinuria, lipiduria, but few cells are cast. Heavy proteinuria means that it's more than 3 grams in 24 hours. Hypoalbuminemia, less than 3. Peripheral edema, and can have the thrombotic disease. Renal biopsy is standard. Don't use the Thai thinking, please. Okay, question number 14. We have another 50 to go. So, no, just joking. Just have like 2 left. 63 years old male, alcoholic. 52 years. 50 pack year history of smoking. Because I have to introduce you the next lecture. Present to the emergency room with fatigue, confused. Physical examination, review blood pressure of 110/70 with no orthostatic change. No orthostatic change again. Okay? Heart, lung, abdominal exam are normal. Don't think anything else is normal. In the exam, it's normal, it's normal. Don't think anything else. There's no pedal edema. No pedal edema. Laboratory data is as follows. So its sodium is very low, 110. I mean, anybody will confuse with 110 sodium. Potassium is 3.7, chloride is 82, bicarb 20. You can see that I can write out the MEQ per liter because I'm just tired. I have to print by myself. Glucose 100, BN5, creatinine 0.7. Urinalysis is normal, spirit is 1 and 16,000. So, which of the following is the most likely diagnosis? Let me give you that. First, volume depletion. We have to rule out the first one first, no orthostatic hypotension. Second, inappropriate secretion of antidiuretic hormone. Psychogenic polydipsia, cirrhosis. Congestive heart failure. They always come to at the end, believe me. You have 30 seconds to think. Very easy. Chiang Mai medical student know everything. Okay, can you have answer, please? This is a real board exam. Sorry, USME exam. It's fun, right? This is the real patient. Can I see the answer? Oh, excellent. That's what we call Chiang Mai medical student. Very nice. Okay, so we just go through it. The clue is that no volume depletion. I teach you already, right? No urine dilution. So specific gravity is very high. So it's no psychogenic polydipsia. This case is drink a lot of water. So we have to be like less than 1/1000, okay? And no edema and ascites, psoriasis, and congestive heart failure unlikely. Oh, did you guys doing good? You passed the exam. So let's go talking about the hyponatremia. First of all, you have to rule out pseudo hyponatremia first by send the serum osmolarity. Very easy. It costs you 250 baht in Bangkok. I don't know how much it costs here. Is it normal? Have to be multiple myeloma and lipid disorder. Is it high? Have to be glucose and mannitol. If it low, is it the real one? Okay. Each 100 milligram of glucose decrease sodium by 1.6. You have to remember this. You're going to be very clever medical student when you go in the round. So after you check that it's not pseudo hyponatremia, you check the volume of the patient. If it's low volume, you probably get a diuretic, GI loss, adrenal insufficiency. High volume, heart failure, cirrhosis, nephrotic syndrome, renal failure. High volume means that swelling, JBP going up, lung crackle. If you're in emergency room, you can use the ultrasound, scan the SVC. If it's no collapsing, means that you have high volume. Normal volume is a SIDH, psychogenic polydipsia, right? SIDH, look, people come with SIDH have to be hyponatremia, normal volume. This one is low serum uric acid. High urine osmolarity than serum osmolarity. Why I have to say that? Because you see a lot of patients like this in the emergency room and in the ward, and you give them 0.9 normal saline, and the patient keep sodium lower and lower every day. Because this kind of case have sodium usually higher, not sodium, urine osmolarity higher in the blood osmolarity. So if you send the urine osmolarity, you have 500 milliosmol, and you give the normal saline 300 milliosmol, end up the patient get a lot of water into the body, and the patient go to seizure tomorrow, and you ask yourself why. My sodium is dropping. The sodium is only 110. I give you 140 MEq per liter of sodium, but the sodium keep dropping because of this problem, because the kidney cannot excrete the water. Okay, don't give 0.9 normal saline as a reflex from your brain. Write down, admit the patient, 0.9 normal saline, 80 cc per hour, 5 normal saline. Don't do that. Okay, calculate the osmolarity in the IV that you give to the patient compared to the urine osmolarity all the time. Question number 15. This is my last one. Oh, I finished early. I think it's my last one. I want to give you this question because you don't see African American patient here in Chiang Mai. I don't think you see a lot. This is 29 years old African American male with HIV on indinavir, sidovudine, and stavudine. Present with severe edema. Serum creatinine of 2. He has a bone pain for 5 years, so he take a lot of paracetamol with codeine, aspirin, ibuprofen, and he's on prophylaxis for PCV with Bactrim. Blood pressure is 170 over 110. Protein have 4 plus. 5 to 10 red cell, 0 white cell. 24-hour urine protein is 6.2 gram. The serum albumin is 1.9. Which of the following is the most likely cause of his renal disease? Read 2 times. Really read the question. Indinavir toxicity, analgesic nephropathy, Bactrim-induced interstitial nephritis, focal glomerulosclerosis, renal artery stenosis. Let's go back again. I know that you never see this kind of case here in Chiang Mai. Very rarely. You see a lot in New York. HIV black people walk to you, have a lot of protein leak in the urine. What the most common? Take a lot of medication. So can I have an answer, please? If you don't get this question, it's okay. If you get the question, you got gold medal from the dean. He's not here anymore. So, wow, you're good. Oh, you're very good. Focal, segmental glomerulosclerosis is the answer. People walking to you with black have protein leak. First of all, you answer that thing is focal sclerosis. It's the most common. Indinavir toxicity may cause tubular obstruction but cannot cause the protein in the urine. Okay? Bactrim-induced interstitial nephritis need to have fever, rash, and white cell cast or something in the urine like eosinophil. Renal artery stenosis have normal urine. HIVAN, or we call HIV-associated nephropathy, is most common in black population in America. It's first reported by Kings County Hospital. It's called FSGS. They have microcytic dilatation of renal tubule, lymphatic interstitial infiltration, interstitial fibrosis, nephrotic syndrome, and it's confirmed by the USRDS. In America, they have a renal data system, and they compile all the incidence of the disease. HIV is the most strongly associated with the black race than any other cause of renal failure with exceptional sickle cell disease. Okay. And another thing you have to know is this. HIVAN, if you don't treat the HIVAN, it takes 3 months to go for the dialysis. So you have to treat the HIVAN with the antiretroviral medication, ACE inhibitor, penicillin, some combination. This is a HIVAN. So you see that like collapsing. It's not like a FSGS. It's like some people poke the hole into the balloon and it collapses everything. The glomerulus is collapsing from the big one to like half the size. And they have a lot of interstitial infiltration, which this is called microcystic dilatation. Okay, I'm finished here. I'm sorry I finished a little bit early. This is thank you, my teacher, or my boss, previous boss, and yeah. Have any question for the nephrology? Many questions from now. You can read into the books. I just go through the way you do the exams, the way you read the sentence. Even you try to get the idea from the sentence when you read the sentence. Okay, a lot of things you have to learn. You have to read a lot. That's pretty sure about that. Question? No? Everything? No. So tomorrow you're going to pass the exam.
And Dr. Sira has to return to Bangkok, so he won't be around later. So
I'm on call tonight, so I have to go back.
So we have time for a question.
I'm very good teacher. They know everything, and teach them. Yeah, today. The copy will be like available with you from the secretary service, so you can get a copy of the handout for the slide.
Okay.
Okay,
Thank you, Dr. Sira.